Respiratory distress syndrome is a major cause of morbidity and mortality in premature infants. Infants with RDS are deficient in pulmonary surfactant. For them, Ross Laboratories has prepared Survanta. This program will explain dosing procedures. Endogenous pulmonary surfactant lowers alveolar surface tension and stabilizes the alveoli against collapse. In infants with RDS, Survanta replenishes surfactant and restores surface activity. Survanta's safety and effectiveness were demonstrated in 10 controlled trials. Additional safety information was obtained from a treatment IND. More than 3,700 infants were treated in all clinical trials using 2 treatment strategies. For prevention, Survanta may be given to premature infants less than 1,250 grams birth weight or those with evidence of surfactant deficiency. Infants are stabilized, weighed, intubated, and given their first dose of Survanta as soon as possible after birth, preferably within 15 minutes. Manual ventilation is used during the initial prevention dosing because these babies are not yet on mechanical ventilators. For rescue, RDS should be confirmed by X-ray and infants should be on mechanical ventilation. Treat as soon as possible, preferably by 8 hours of age. Continuing respiratory distress indicates the need for additional Survanta. If the infant remains intubated and requires at least 30% inspired oxygen to maintain a PaO2 less than or equal to 80 torr, give additional Survanta no sooner than 6 hours after the preceding dose. For infants who received a prevention dose, radiographically confirm RDS before giving additional Survanta. For all infants, each dose of Survanta is administered through a modified 5 French end-hole catheter inserted through an endotracheal tube with the distal end lying above the carina. Each dose is 100 milligrams phospholipids per kilogram birth weight, given in 4 quarter doses. Marked improvements in oxygenation may occur within minutes of administration of Survanta. Frequent and careful clinical observation and monitoring of systemic oxygenation are essential to avoid hyperoxia. Each vial of Survanta contains 200 milligrams of phospholipids in an 8 milliliter suspension and should be used only once. Because the drug is stored in a refrigerator, allow it to warm adequately before use. Hold the vial in the hand for about 8 minutes, or let it stand at room temperature for at least 20 minutes. Artificial warming methods should not be used. Inspect the suspension. Its color should be off-white to light brown. If settling has occurred, swirl the vial gently. Do not shake the vial. Be careful to minimize foaming the suspension. If a prevention dose is to be given, preparation of Survanta should begin before the infant's birth. In controlled clinical trials, prevention dosing with Survanta reduced the incidence of RDS by up to 70%. A single study is illustrated, but others showed similar results. Deaths due to RDS were reduced up to 87% by the prevention strategy. Prevention dosing begins with a review of maternal records.
They just finished an ultrasound which shows her size is consistent with their dates of 25 weeks.
Identify those infants who are at risk for RDS, typically those who are expected to weigh less than 1,250 grams. Larger infants with prenatal evidence of surfactant deficiency may also be treated. Have a 10 milliliter syringe and a vial of Survanta at room temperature available in the delivery room. Start prevention dosing as soon as possible, preferably within 15 minutes after birth. In cases of expected multiple births, several people may be needed to dose the infants quickly. Immediately after birth, suction the oropharynx and place an endotracheal tube. Note the tube length. Confirm tube placement by auscultation. Next, weigh the infant. Cut a 5 French end-hole catheter to match the noted length of the endotracheal tube. Use a duplicate endotracheal tube for reference. Fill the syringe with Survanta. Attach the modified catheter. The dosage is based on the infant's birth weight. Expel the excess through the catheter, leaving the full dosage in the syringe. The drug is given in 4-quarter doses. Each portion is instilled with the infant in one of 4 positions. The specific sequence is not important as long as all 4 positions are used. Once the infant is stabilized, position the head and one shoulder slightly down. Insert the cut catheter fully into the endotracheal tube. Inject the first quarter dose over 2 to 3 seconds. Gravity will help distribute the liquid. Manually ventilate for 30 seconds. The bag must be equipped with a manometer and must be capable of delivering 100% oxygen. Ventilate to prevent cyanosis and to provide adequate air exchange and chest wall excursion. Next, rotate the infant on the cephalocaudal axis so that the head and other shoulder are slightly down. Inject the second quarter dose over 2 to 3 seconds. Manually ventilate for 30 seconds. Now position the head and one shoulder slightly up. Inject the third quarter dose and ventilate. Finally, rotate the infant on the cephalocaudal axis so that head and opposite shoulder are slightly up. Inject the fourth quarter dose, and without flushing it, remove the adapted catheter. Again, manually ventilate for 30 seconds. As soon as possible, move the infant to the NICU. Provide adequate ventilation and oxygenation during transport.
Did respiratory therapy get the ventilator settings?
In controlled clinical trials, rescue dosing with Survanta reduced deaths due to RDS by up to 68%. Infants with confirmed respiratory distress syndrome may be treated using the rescue strategy. They should be treated as soon as possible after being placed on a ventilator. The RDS should be confirmed by X-ray and be severe enough to require assisted ventilation. For rescue, Survanta is again given in 4-quarter doses through a modified 5 French catheter placed in an endotracheal tube in each of 4 positions. After each quarter dose, infants are mechanically ventilated for 30 seconds. In clinical trials, ventilator settings were standardized during dosing. These settings may be adjusted for adequate oxygenation and ventilation during the procedure.
Is the Survanta warm?
Prepare for rescue dosing with a 10-milliliter syringe and a vial of Survanta warmed to room temperature. Dosage is again based on birth weight. Fill the syringe with Survanta. Cut a 5 French end-hole catheter to match the endotracheal tube length. Attach the modified catheter and prime it. Leave only the full dosage in the syringe. Position the infant's head and one shoulder slightly down.
Down.
Insert the modified catheter fully into the endotracheal tube. Inject the first quarter dose. Mechanically ventilate for 30 seconds to distribute the drug. Next, rotate on the cephalocaudal axis to position the head and the other shoulder slightly down. Inject the second quarter dose. Mechanically ventilate. Now position the head and one shoulder slightly up.
Head to the right again. Okay.
Inject the third quarter dose. And ventilate. Finally, rotate to position the head and opposite shoulder slightly up.
Okay.
Inject the fourth quarter dose. Remove the adapted catheter. Do not flush it first. Ventilate for 30 seconds. Regardless of the strategy used, follow certain observation and monitoring procedures. Stay with the infants after dosing. Adjust the inspired oxygen to maintain an adequate PaO2 or transcutaneous PO2. Survanta may act quickly on oxygenation and lung compliance. After dosing, closely monitor oxygen status, airway pressure, and respiratory rate. Make appropriate adjustments when compliance or oxygenation improve or if cyanosis or bradycardia occur. Do not suction the endotracheal tube for 1 hour following treatment unless occlusion is suspected. Continue to ventilate as needed. Retreatment with Survanta is virtually identical to initial dosing procedures. For all infants, however, mechanical ventilation is now used and settings may differ slightly. During clinical trials, retreated infants had X-ray documented RDS and were intubated. Their PaO2 was less than or equal to 80 torr and at least 30% oxygen. At least 6 hours had elapsed since previous treatments. Before retreating, warm the drug to room temperature. Suction and stabilize the infant before dosing. Increase FiO2 sufficiently to prevent cyanosis. Set a rate of at least 30 per minute with an inspiratory time of less than or equal to 1 second. Settings may be adjusted to ensure adequate oxygenation and ventilation. Cut a 5 French open-end catheter to match the endotracheal tube length. Base dosage on the infant's birth weight. As before, administer Survanta in 4 quarter doses. Do not flush the catheter after dosing. Remain with the patient until stable. Ventilator changes may be made when compliance improves or if acute deterioration occurs. In controlled clinical trials, Survanta decreased the incidence of RDS. The risk of pulmonary interstitial emphysema and pulmonary air leaks were reduced. There was no increase in allergic manifestations compared to control groups. Most importantly, clinicians using Survanta saved many lives.